नमामि धन्वन्तरिमादिदेवम् सुरासुरैर्वन्दितपादपद्मम् लोकैर्जरारुभय मृत्युनाशम् धातारमीशम् विविधौषधीनाम्.
Yogesh asked me to speak on the diagnosis and management of skin diseases in integrative medicine. So, thank you, Dr. Yogesh, for the opportunity. Let me tell at the outset the paradigm on which I am speaking about integrative medicine. The integrative medicine which is speaking about today, there is no consensus on what is integrative medicine. But we stick to what the British Medical Journal in 2001 wrote about integrative medicine in its editorial. The use of interventions from traditional medical practice alongside the medical treatments and principles for a biomedical diagnosis is integrative medicine. So our work is confined to this paradigm where diagnosis is allopathy or biomedical diagnosis, and all the outcome measures and how the patient has improved is decided by allopathic measures. But the traditional Ayurveda or yoga or homeopathy or any Ayush treatments are given alongside the allopathy treatments whenever necessary. As we all know, Indian government made integrated medicine legal. It is now introduced to the medical curriculum as well. The Niti Aayog, National Institution for Transformation of India, has given a policy approval for integrated medicine as a part of the national health policy in 2017. So it emphasizes the use of integrated medicine for chronic diseases. National Ayush Mission is also emphasizing on the integrated treatments and is planning to roll out integrative medicine as part of the public health programs. Although we are way back, in 1991, the NIH USA began the whole program with establishing what is known as Office of SCAM, which is now the National Center for Complementary and Integrative Medicine, Integrative Health. The NABH, the NAM, the ICMR, and other Indian government bodies are now following. But I am happy to note here is that in Kerala, we have been trying to get the approval for integrative medicine because there was a lot of resistance in the judicial system, a lot of resistance in the bureaucracy and in the research funding agencies to really support the integrative medicine. That's the time when the Kerala Assembly interfered and it passed a resolution in 2014 February to set up a Center for Integrated Medicine and Public Health within our institution as an annex. And you can see the Revenue Minister E. Chandrasekhan inaugurating the Center for Integrated Medicine and Public Health with the approval of the Governor of Kerala. So this can be told as the first ever official Center for Integrated Medicine in this country, in India. So what is the clinical setting with which we work? One important thing is that all disciplines and systems of medicine have the equal status. I must emphasize status and opportunities to involve the treatment plans, involve in the treatment plans. That is biomedicine in depending upon the specialty, Ayurveda, yoga, and homeopathy, or whatever the system integrated. So we use a measurable, unambiguous tools and blood investigations to record evidences. So from bedside to the objective evidences are also made. But we emphasize that molecular and surrogate markers are less important in the clinical work. We identify the clinical outcome measures in all systems. Photography is important. Photography studio is important as we work in dermatology. We always have an electronic medical record system to support the physical case records. The clinical integration comes by the doctors of all systems, allopathy, Ayurveda, homeopathy, nurses, everyone, examining the patient together at the bedside and then discussing. So here we take the measurable treatment outcomes. That's very, very important. Using the system medicine and bringing them together. That means we have to take the measurable treatment outcomes of any system which is integrated along with the biomedical system. In this case, dermatology. Say, for example, scoring systems in dermatology is a small book which gives very many internationally accepted scoring systems and outcome measures. If you go to the PubMed, we can get the recent updates. Medscape, we can get the recent updates. So biomedical tools and scores are used, but it should be previously been shown to measure what it claims to measure. In Ayurveda, the concept existed as Falashruti. We can't say that it's yes, your all tools are already there in Ayurveda. No, the concept existed, but that has to be made clinically relevant for today. So we have to use the descriptive clinical features. For example, they may say Kafa Medo Hara or Pitto Hara. Then we have to explain in the clinical terms of today's allopathy of what does it mean. So that's a Falashruti. And we should always deal with confounders and group them at the baseline. See, confounders are like, I always say, confounder is like poverty. Poverty exists everywhere in the world. You take the developed nation or you take the Indian condition. If you compare Western medicine as a developed medicine, there is also confounders are there. And of course, in Ayurveda, confounders are plenty. And you know our confounders. We all deal with political systems and we make the APL card, BPL card, APL fellow becomes a BPL fellow and real BPL fellow becomes graded as APL and so many things. So confounders are very tricky and they need to be grouped and they need to be looked at in the beginning. The follow-up must be continued for long enough for the treatment to reflect the outcome variable. See, the outcomes should be something like this. In lymphedema, it's a volume reduction. You can see that this is the kind of volume reduction and you can see the dates there below. In let's say about 1 month's time or let's say about 2 weeks' time, there is a significant reduction. So this can be measured with the tape, it can be measured with water displacement and so on. So this can be measured. There are, if you want to use the latest technology, LymphaTech is there, which gives you 3-dimensional views and measurement. All that is possible. So that is what is essentially saying is that the outcome should be measurable. When it is done and we are convinced that the integrative medicine treatment works, then we invite the world experts on the each system. Here you can see Professor Baghel of Ayurveda teaching at the bedside about Ayurveda to Professor Peter Mortimer of St. George's, London, explaining a patient with a chronic wound and lymphedema and how they are taken treatment and how they're responding. So we get a consensus of the world experts on the outcome measures. And we define what is the patient population. So I am explaining you how we can describe psoriasis. Let us define this lesion. This arrow should have been here. In dermatology, we call this annula. In Ayurveda, it is called mandala. Erythematous in Ayurveda, Raktavarna. Xerosis in dermatology, Ruksha or Parusha in Ayurveda. Uneven surface becomes Khara in Ayurveda. It is gutted psoriasis. And there's a name called Mandala Kushta in Ayurveda. So clinical examination in integrative medicine gives a mutual orientation with the different medical systems. I'm taking up this example of this patient. Let us describe these lesions. It's violaceous in color. You call Shavara resistant. It's elevated. It's usteda. It's xerosis. And like that, we can describe when it's called pruritic, it becomes kando. It becomes lichen planus in dermatology. There is no specific name given in Ayurveda for this disease. So let us explain the comparable medical terms in lymphedema. I am describing this area. It's Krishna or black pigmentation. I am describing this area. This is Ruksha or xerosis. I am describing this area. Sputana, you can see a lot of fissures there. And fissures. And it becomes vata. So we have to describe the Staniya Vikriti. I will describe it in the case of vitiligo called Shvitra in Ayurveda. Carefully observe this vitiligo lesion. A lot of hairs are there. Let me describe this area. It becomes Roma Vidvamsa. So we give the contemporary interpretation for Roma Vidvamsa because absence of hair on the lesional skin in hairy area. Very important. Otherwise, Roma Vidvamsa becomes leprosy. So we need to distinguish leprosy from vitiligo. So if you have to describe this, it becomes color of the lotus petal. So it is pitta. So the final diagnosis is similar, but the nomenclature are different. In this mutual orientation, both systems learn from each other. Let us say this is vitiligo. This becomes Shvitra. This is lymphatic filariasis, Sleepada. This is non-healing leg ulcer, Dushtavrana. So when we examine this, we put up a table called Staniya Vikriti table. So we have to describe Vata, Pitta, and Kapha in the Staniya Vikriti table and explain what are all there. So why it is important? Because Ayurveda selects drug selection for a chosen patient. Whereas in biomedicine, we are doing a patient selection for a chosen drug. You look at the difference in the approach. The drug is there, the patient is selected. Patient is there in allopathy, drug is selected. So we can imagine the level of side effects variation. So when we define this Vata, Pitta, Kapha in the form of a Staniya Vikriti, we will be able to develop a table like this of the comparable biomedical terms. So the Sthaniya Vikriti table of the comparable biomedical terms, maybe after 50 patients, maybe of 100 patients, we will be able to define. We have published in Journal of Lymphedema. What happens? To our surprise, that we defined this way back in 2011. But then over 10 years, now we have seen more than 4,500 lymphedema patients. The Sthaniya Vikriti table, we have not come across the need to change it. So that is the clarity we get when we work together. This is the Sthaniya Vikriti table for a vitiligo patient, the Vata Sthaniya Vikriti table. In yellow, it's a Ruksha, Aruna, Mandala, Parusha, Paridvamsi, and so on. So it has a parallel biomedical terms. So this is the Vata Sthaniya Vikriti. We have written all these and published it in International Journal of Dermatology. And it's a 24-page document. It's available and anybody can read it. And we have described exactly how to do the integrative medicine approach, develop a program and monitor it. But we have to adhere to the basics. If it cannot be explained, let us say an Ayurvedic principle cannot be explained by a modern science, or a modern science principle is to be difficult to understood by the Ayurvedic person as a science, not as an expert. State so, accept it, but don't ignore it, include it. So deciding factor in the integration therapy is this: adhere to the basics and retain what cannot be explained, accept them. Do not ignore that because it cannot be explained, it is not true. We came to know this and we learned it in a hard way, that the patient selection is the most important thing in integrative medicine. And it take to the bedside approach, but read at least 7 books, starting from the clinical methods of the medicine, surgery, Ayurveda, and homeopathy. So in the clinical methods, biomedicine says system by system examination, which is Amsha Kalpana of Ayurveda. So we have described that in complete details, how exactly to do in English language after examining many thousands of patients together. When we compared the clinical methods, Ayurveda does it through dosha theories and personalized medicine and holistic system and so on. Meaning clinical presentations and its pathophysiology, including what can be explained and what cannot be explained, which is equal to biomedicine clinical presentations and diagnosis and comorbidities. Clinical methods and differential diagnosis are in the great more details than Ayurveda in biomedicine. So in integration, Ayurveda gains in its clinical methods. And there are certain clinical methods which are described in Ayurveda, which you learn later in this lecture, which is useful for biomedicine. So mutual orientation enriches the patient examination, biomedicine and Ayurveda. The Amsha Kalpana goes beyond Dashavida Paraksha. In the undergraduate teaching Dashavida Pariksha. Everybody says Dashavida Pariksha. But we categorize the clinical methods because Ayurveda elicits the patient information and not as a systemized data and separate it like in allopathy. When we raise the clinical methods in Ayurveda and categorize them, we listed 16 categories. When grouped together, these details contribute to the Ayurvedic diagnosis and drug selection. You can see that each Prakriti, dosha, dusha, all that have large number of variables. Dosha has 3 into 6 into 3 into 8. So 7 into 2 into 16 for dosha. So these are the data available in the clinical methods. So we thought in this process that our Kshudra Kushta lesion is a lesional skin morphology, or should we retain its name only as a disease, or Kshudra Kushta is a lesional morphology. Because Kshudra Kushta is said to be named and unnamed. And the teaching says it's disease. Of course, we did not touch the major diseases of 7, Kapala, Udumbara, and so on. Whereas minor diseases, we thought it could be lesional morphology, many depending upon the dosha combinations. The lesional skin examined according to, even in Ayurveda, color, shape, appearance, sensation, spreading in the body, pain, and discharge. So why call them a disease? Why not call them as a lesional morphology? Kshudra Kushta as a lesional morphology. Why not try to treat it with a different medicine, instead group them? So this is a dominant. Vata dominant, Kapala is a dominant. There is a very clear description. So in dermatology, similarity is there because we describe history, we describe morphology, pattern distribution, visual diagnosis, and many other things. There's a large list here, like the presenting complaint, general history, examination of the skin, and so on. And that can be grouped. We group it. So we found out that there could be some comparison between the two, because dermatology is also not well developed as cardiology within the allopathy domain. So we thought, why not group them? Why not Kshudra Kushta also can be grouped? So that's a Rook's textbook. So we developed a robust patient database where all the clinical features, personal details, disease condition, history, prescribed medication, treatment details, photogallery, everything is brought into one system. We use the Bhamini open access. Anyone can look into bhamini.org. We contributed to as many as 1,600 concepts to Bhamini. Because it's open access, we described all this in conjunction with the SNOMED. So we try to adhere to SNOMED. Whenever SNOMED is not available, describing, we just uploaded it to the Bhamini. Probably SNOMED can get better off by looking at Bhamini. So in this process, we found out that Ayurveda prescriptions also follow a pattern. Shvitra with Kapha dominance, two prescriptions we see, it has similar. In the same way, like this, there's an example of Vicharchika with the same Kapha dominance, Pitta Kapha dominance. So what happens? We did a small study of observer masked dosha vaishamya to prescription correlation. We have asked the patient, we have asked the observer, Ayurveda doctors to look at the dosha vaishamya. We have asked the allopathy doctors to look at the patient, kept them blind. But there was a diagnosis, plaque psoriasis. And observers Ayurveda doctors made a diagnosis of Eka Kushta. There was a plaque psoriasis, Kitipa Kushta. There was a plaque psoriasis, gutted psoriasis, and Mandala Kushta. So we tried to correlate observer masked, all of them came out with the same diagnosis. And what happened? We asked them to say what is that dosha dominance is there, what is the kind of treatment you can give. And then they wrote down some prescriptions. And then we could get some similarities. So what we saw with the patients when they came back that we have taken the Ayurveda treatment, when they came with saying that we have taken the Ayurveda treatment, it didn't work. Then we compared it with a small internal study and found out that it is true. So we decided that grouping the different nomenclature is important, because if I go back, psoriasis is described by different names in Ayurveda. So we thought, let us group them. And when we started grouping them, we came to know that Ayurveda described different stages of the diseases by different names. If you look at lichen planus here, the figure A is lichen rubor planus. You can say erythematous or raga, annular or mandala, papular or pidaka, dadru. Hypertrophied lichen planus is described in B and C. The hyperpigmentation observed in the middle, surrounded by violaceous color. The lesions are thickened ghana, elevated usteda, with rough edges, rukshambahi, kapha vata dominance. So different stages of the disease in the biomedicine has different nomenclature in Ayurveda. So when it's grouped, a lot of things happen there. So disease staging or roga avastha is important. It brings more treatment options for the same disease. So probably in Ayurveda itself, there's a repurposing. So many Ayurveda doctors say that by doing the integration, repurposed drugs are beneficial to allopathy medicine or biomedicine. But I am trying to say that when we do the staging of the disease, repurposed drug is helping Ayurveda itself. So in this disease, A is Ekakushta, B is Sidma, D is Mandala. It all has a different names in psoriasis. So for psoriasis, you have a repurposed drug of Ayurvedic doctors have a repurposed drugs for Ayurvedic medicine itself. So it's not repurposing only for Ayurveda, only for allopathy. It's also for Ayurveda. But what Ayurveda also gains is the differential diagnosis, because it's not well developed in Ayush. Biomedical collaboration and investigation is mandatory for this purpose. You see this Tambravarna, and this is also Tambravarna, and Ayurveda classifies it under vitiligo. But I would say that coppery red lesions means leprosy in biomedicine. I don't want to treat it as vitiligo. Look at this clinical lead. There is the same dosha dominance on either side. Erythema or raktavarna, discharge or srava, papular lesions or pidaka has a pitta dominance. Okay, but same treatment given, A patient responded, B patient did not respond. Because B patient gave a complaint of pain, developed pain during the treatment. We all thought that this is due to this ulcer. But the Ayurveda doctor says there is a vata dominant. He is developing pain. We initially ignored. But Ayurveda doctor insisted. Then we angrily went for biopsy, saying that this is Slipida. But we found out that this is sarcoma. So each amsha kalpana is important. Let us not ignore what Ayurveda says. He says pain, don't say that vata doesn't exist, so we will not important. So in the biopsy, we said that lymphedema had the sarcoma developing in that. This was just lymphedema with lymphangiectasia. So there's a learning for both Ayurveda and allopathy. Look at this Amshamsha Kalpana process which elicits Pitta Vata Prakopa. There is edema, which is Kapha. There is erythema, which is Raga. There is warmth, of course, you can't touch it now. There is Vata or pain. Now, this is a Prakopa. So, integrative medicine excludes these kinds of manifestations using Ayurvedic clinical features. This contradicts the allopathic understanding of sepsis. So, whenever it really contradicts the allopathic understanding, I am saying contradicts. I am not saying it cannot be explained by allopathy. When it contradicts the allopathic understanding, acute care needs are important, curable by a medicine. It should be identified. We have written all these and published. There is an atlas of integrative medicine available for skin diseases online, free. So there is a lot of importance to ama, diet, kosta, agni. All that is there. I'm using the same Ayurvedic words because they don't mean exactly the gastritis. Agni doesn't mean exactly the gastritis. So I'm not going to explain because there's no time to do that. But we need to consider this when we do the clinical methods. So when we have done all this, we get integrative medicine treatment for lymphedema, transformed a non-treatable disease to a treatable condition. In Ayurveda also it is asadhya. In allopathy also, get out, we don't have a treatment, but we are able to treat it with integrative medicine. So component of Fanta, compression therapy, then there is yoga, there is massage, and you can see the baseline photo, you can see the follow-up photo. All the details of how we treat it is available in the YouTube channels. Anybody can look into the YouTube channel. There's a link given in this slide. How even the breast cancer related lymphedema is treated using this protocol is also explained. I'm not talking details. So integrative medicine bridges the gaps in biomedicine and Ayurveda. It transforms Ayurveda into evidence-based Ayurveda because it adopts investigations and effectiveness in outcomes, explains the clinical methods and science, and expands it. And the staging of the disease is possible. Differential diagnosis is benefited, allows the repurposing the drugs within Ayurveda. Whereas allopathy has a lot of advantage of intersectoral collaboration, which leads to evidence-based use of traditional medicines for all. Ayurveda and yoga can be used as innovative care for chronic conditions. More herb-based candidates are possible. Prakriti studies will add to pharmacodynamics. Understand this. Pharmacodynamics meaning what body does to the drug. So integrating therapies should not compromise the biomedical pathology, neither should it compromise the Ayush principles. If you look at the ISS consensus requirement, that is International Society of Lymphology consensus requirement, to treat lymphedema, there is a need to do the skin care to improve the barrier function of the skin. Here. So in Ayurveda, Fanta soaking to heal the chronic wounds to improve the barrier function. Care of the bacterial entry points are important. Lymph discharge is there, for which we are using Uddvartana or Vimlapana. We renamed it as Indian manual lymph drainage. Breathing is important. We are bringing yoga, not compromising on how breathing is done. We are using yoga, just yoga, because breathing is there. Movements, you are using yoga as movement. We are not using physiotherapy, modified physiotherapy. Compression is always available in both modern medicine and Ayurveda. dietary toxins influence disease. This is Ama and Kushta. And if you ignore the principles of Ayurveda, what happens? This is at the baseline, Ayurveda. Baseline in Ayurveda, the doctor said the patient has Ama. So I said, there is nothing called Ama. I'm talking about 10 years backstory or 15 years backstory. I said, it's only a gastritis, don't worry. You give ranitidine. So we prevented the Ayurveda doctor to treat the Vishamagni or Ama. Sorry, Ama, we prevented him treating. So the patient came back for follow-up. This is what happened. Increased. Then we said, no. Vitiligo is known to spontaneously increase and it is not due to your Ama. But Ayurveda doctor, because I said in our setting there's equal preference, this time asserted, said it should be treated as I want to treat. So we said, okay, the patient did Amapachana. The doctor did Amapachana. The patient came back, follow up. The treatment result after Amapachana, you can see there is a reduction. And now the allopathy doctor will say that it is a spontaneous repigmentation. Then we looked into what is spontaneous repigmentation. The spontaneous repigmentation is the repigmentation as it happens here. But the depigmentation which is there should also expand. Then only it is called spontaneous repigmentation. But here there is a repigmentation which is happening. The depigmentation is not expanding. So we cannot classify this as spontaneous repigmentation. So this is the Ama treatment which helped. So it's important that we take a holistic view. Now, yoga adapted based on the available evidence. For example, Peter Mortimer published way back in 1990 that's a small amplitude movement in ankle takes up the radio isolate clearance of lymph. So we used Gulfa Chakrasana and Gulfa Namanasana, but we used it as is. We did not compromise. Yoga initiates mobilization because patients don't want to move with big limbs. We said yoga works, it helps you, they are motivated. Yoga asana induces a lot of dermal stretch. You can see in Trikonasana how the patient is stretching. If you look at this picture, see in the normal picture of Atlas in anatomy or any dermatology books, you don't get this lymph capillaries because normally lymph capillaries are not seen. It is dilated only lymphedema or whenever there is a block. So when there is a stretch, there's a pressure and it drains. I'm not going to the details of how we can explain the lymphedema, how does lymphedema work. It's a separate lecture by itself. So later on, we did biopsy and found out what is that lymphedema contains. And then we proved that it contains type 3 and type 1 collagen are overexpressed at the RNA level. So we defined, our integrative medicine defined what lymphedema is inside. And we changed the practice of lymphedema worldwide. So now we need to prove that what is reversed is not the lymph by compression. As I explained the spontaneous repigmentation before, people will very easily say that compression bandaging is pushing up the lymph. But we here I have to explain that now we explained that RNA is overexpressed, type 3 and type 2 DNA, type 2 collagen RNA is overexpressed. After the treatment, we have to see that the downgrading of this RNA. Of course, it needs funds. We don't have that funds to do that. When we get it, we will do it. And when we'll do it, we will prove it like this. So the response is very much sustained. You can see a 1 year, you can see a 15-year response. And developing a treatment protocol of integrative medicine requires a sound knowledge of applied and translation medicine science. So it's very important that we know, we read Ayush, we read biomedicine, we read cell science and signaling, we read botany, we read bioscience, we read reverse pharmacology, we read anthology, everything as a clinician-led program. We work with patients. We work not with only disease, we work with patients. And that is integrative medicine. And look for non-PubMed sources for Ayush. Very, very important. Electronic search, non-PubMed sources. Here I want to emphasize that electronic search alone is not sufficient for Ayush, because unfortunately, electronic search is not sufficient. The Ayush portal, which is maintained by the Ministry of Ayush, is not updated. It is not comprehensive, which can be done. If it is given to the enthusiasts, it can be done. But somehow it's not given. The government system is not giving it. Before we did the Ayush portal, Ayush portal came, we did not do the Ayush portal, I'm sorry. When Ayush portal came, we shown to the world to the search, how to search Ayurveda literature. And then the Ayush portal came. But they are not maintaining properly. If it is maintained properly, very useful it will be. So probably Baghel was fed up with them. And then he published on International Catalog on Ayurveda Publications. Now his student Girish KJ in Hassan, STM Medical College, Dr. Girish KJ, he is taking this forward. And I appeal to Girish KJ, if he ever listens to this lecture, that don't stop here. Persuade and make the Ayush portal very strong, make it electronic search. There are a lot of unpublished electronically material which is useful. And that is what we call Baghel's hand searching. So Baghelji guided in many ways. He initiated many things. And I'm sure his student, the current Secretary for Ayush, Rajesh Koteja Sahab, will take all the dreams of Baghelji forward, which is useful. Baghelji always encouraged anybody who worked with Ayurveda. He never said Ayurveda is for Ayurvedists. He worked with, I could see when the Cody's chairman came to our program, he started discussing with Cody's chairman and said, this is the equipment you can develop. This will be useful for the drug manufacturers of Ayurveda. So he worked with patients. You can see a lot of patients standing around. He worked with international experts. He worked with government. He worked with allopathics. He was a true pioneer of integrative medicine. He supported it. We need luminaries like Ayurveda. I am sure a lot of students are becoming luminaries of Ayurveda, are already luminaries of Ayurveda. And we need to work with them so that both Ayurveda gains, both patients gain, both allopathy gains, patients gain, and after all, the world gains, the health is better, disease gets controlled. Thank you very much.